Are we online? We're not.
It says we're online.
It says we are online, so we go and we are online. Welcome, everyone. Hello to the European Regional webinar on the priorities and policy papers proposed for the August meeting. Let me just quickly add you here because the settings are different. Stream my screen, and then we will directly jump into seeing what else. But the option is gone. Hi. Screen share. All right, everyone should see now our wonderful presentation regarding the European region. And on that one, we don't see it. We see it, right? Yes. We go basically into the priorities and policies. Today with me, we have Valentina, our General Assistant for Europe, focusing on AMR currently. Then we have Kim, our Regional Assistant for the Standing Committee on Public Health. Friederike, our Regional Assistant for the Standing Committee of Reproductive Health, including HIV and AIDS. Katharina, our SCOME girl, our Regional Assistant for the Standing Committee on Medical Education. And my name is Birk. I'm the current Regional Director for Europe of the International Federation of Medical Students Associations, the channel you're currently on. And very important for that one is that you take care and say like, subscribe, and ring the bell for any other notifications, because we have plenty of webinars or materials sharing here on YouTube. And if you want to be part of it and be informed that it's happening, just be there. We will directly jump into topic and we'll talk briefly about policy in general. And there I will give the floor to Kim. But before we do that one, just briefly, what are regional priorities and why do we have them? So we have for quite a long time already IFMSA divided in the 5 regions. So we have the Americas, Europe, Africa, Eastern Mediterranean region, and the Asia Pacific region. And it was divided to basically have a null overview and a different idea about every region has a different problem, and we have to face these problems on a regional level. And with those regional implementation, we also started to have regional priorities. Of course, we are a global federation and we will continue working on global scale, but sometimes we have to address topics on a regional level. And currently we are tackling antimicrobial resistance on European level and the health and rights of refugees. But once a year, we can as region decide what to focus on next. And we can have a maximum of 3 annual advocacy priorities per year. So that means we have 6 proposed, and out of those 6, we can vote for 2 or 3 at the upcoming August meeting in Canada, Quebec, in the city of Montreal. All right, let's jump to Kim and her wonderful, briefly idea about policies.
Yes, so to get everyone a bit on the same level of what a policy document is, IFMSA uses policy documents to communicate its beliefs regarding a particular issue, and the beliefs are in general kept within the constitutions and bylaws, and the documents that we write are valid for a period of 3 years. So if we vote on them, they will be valid for 3 years and then will be revised. For the people that already have read a policy document before, know that it is consisting of both a policy statement and a policy paper. So if we look at the policy statement, it consists of a short introduction, which is usually a summary of the policy paper. So the policy paper consists of the total background of the topic you're discussing. So for example, we're talking about mental health, and the policy paper describes mental health and why it is important. And you use that to make a short introduction for the policy statement. After the short introduction, which is usually a quarter of a page, we have the IFMSA position, and it is explaining what IFMSA's opinion is on this particular issue. So for example, mental health, antimicrobial resistance. And after that, we have the call of action. So that is what the IFMSA recommends governments, the World Health Organization, universities, medical faculties, national member organization, European governments, etc., what to do. And that should, again, reflect the basis, objective, and goals of the IFMSA. So it is pretty straightforward. Then, in general, why do we have policy advocacy? In general, if we look at policy advocacy, there are many definitions available, but the core idea is that we want to have a strategy to affect policy and change or action. The primary audience is usually decision makers, whether that is at a level of the World Health Organization or a government level or medical faculty level, but that is what you want to change. In the center, if we talk about policy advocacy, it can address issues that are for long term. It can solve problems for a large population at once. It can shift resources where they are most needed. It invites citizens' involvement and problem solving, and it can create enduring change. So that is the core of policy advocacy and why we're writing those policy documents. So if you're ever going to an external meeting, for example, you will use those policy documents as a guidance in how you're going to advocate for that, what IFMSA wants to accomplish. Any questions regarding that? Sorry if I went a bit fast. Okay, I think we can go on to the antimicrobial resistance one then.
Okay, thank you very much, Kim. We will continue with AMR, the antimicrobial resistance, as you said. And for that one, we have Valentina, our general assistant for Europe, who is currently working on the topic.
Okay, perfect. So let's begin with AMR. AMR has been, let's start with what AMR is. It's actually when bacteria and other microbials are exposed to antimicrobials, they become resistant. So the current therapy that you're giving to the patient doesn't work anymore. It's recognized as one of the global and European threats, one of the biggest in public health. So the predictions for 250 are not the brightest. And it brings like the huge burden to people and the huge economic burden to all the European countries. It's been a priority for past 3 years. And at high-level meetings, they are currently saying that we should keep it as a priority because a lot of things has been done, but we will lose all the progress if we stop with all the things that we're currently doing. So if we go to the policy, you can see the IFMSA position. So as I said, we recognize it as a global threat and one of the gravest threats. And we need to tackle all the sectors and find the solutions and also try to put One Health approach proposed by European Commission to practice. So if we go to the next slide, we see that we wrote to call on the EU government, WHO, medical universities, hospitals, and healthcare settings, IFMSA animals, and at the last one, to the public. So the core things that we can do is we can change behavior and try to get people to use antimicrobials appropriate in all the sectors. So that means all the sectors in human health, in animal health, industrial, and in the environment. So the other thing that is in the behavioral change is how to keep and monitor strict hospital hygiene and sterility. So we prevent hospital-acquired infections. And then some more things on how to develop national action plans, strategies, have guidelines on prudent use, ensure that we are as students and other healthcare students are trained appropriate. Of course, we have to encourage also people to get vaccinated and raise awareness among students, healthcare workers. So this is in brief all that we called on in the priority and in the proposal for policy paper. Any questions? Okay, so if there are no questions, then we go on.
All right, thank you very much, Valentina. We are really sorry for the connection issues, but sometimes it happens that we are somewhere in Europe where we don't have connections, apparently. but that's not a big deal. So we continue with our next topic. It's mental health, and you will once again hear our speaker, Kim, as regional assistant for SCOF.
Yes, thank you. So mental health is currently the regional priority for SCOF Europe as well. And why it is important is mostly that because according to the most recent available data, mental health disorders rank first at the cause of years lived with disability in Europe. Over 38% of all European citizens suffer from a mental health disorder once in their life. Unipolar depression of these is the biggest contributor to the burden of disease, and intentional self-harm is being the leading cause of death among young Europeans, which are aged about 15 and 29. However, although we have this enormous burden in the European region, social stigma and discrimination make it often harder for people with mental health issues to recover. For example, their health-seeking behavior is limited, social integration is limited, their access to housing and employment is limited. And globally, if we look at the amount of stigma people receive, we see that there's twice as likely to experience stigma as people that are suffering from physical disabilities. And the World Health Organization within Europe therefore recognizes this as one of the top public health challenges that are currently in Europe. So that's why it is important. Then if we look at the policy document, it once again exists of an introduction and the IFMSA position. So in the IFMSA position, we are kind of aligning with the European Mental Health Action Plan that is made in 2013-2020. And it is based on the fact that we recognize mental health disorders as one of the top public health challenges in our region, and that we affirm the necessity to reduce the burden of mental disorders and to improve equitable access to mental health care. Thereby, we acknowledge that we need to follow the values of fairness, empowerment, and safety. So fairness meaning that everyone has the same right to be enabled to reach the highest level of mental health and to be offered support proportional to their needs. And that any form of neglect, prejudice, or discrimination hindering equitable access is tackled. Empowered meaning that people suffering from mental health problems have the right to be autonomous and to have the opportunity to take responsibility for and to share the decisions affecting their mental health and well-being. And safety in regard to that intervention and activities to promote mental health should be safe and effective and able to show the benefits to mental health and well-being for the population. So that is the IFMSA position. If we then look to the call of action, by the way, did we get questions? Because I heard like beeps. I don't know if that is.
So far, I don't see any questions.
Oh, that's weird. Okay, sorry for the interruption. So then if we look at the policy document, the call to action is mostly focused on local and national government, the World Health Organization Europe and European institutions, universities and medical faculties, and NMOs. And the core part of our call to action is to improve the access to services, so to make sure that everyone has the same access to mental health services as they need, to reduce the stigma on mental health, to protect vulnerable groups, including students. So the policy document has a specific paragraph that is describing the burden of mental health issues within medical students. To educate students, so to incorporate mental health more into the medical curriculum, and to create awareness amongst the lay public, so the general public, to create more awareness about what mental health is and how it can be treated if someone has a mental health disorder. The policy paper itself exists of the public health burden of mental health, so it explains what the burden currently is. It explains the determinants of mental health, so how is mental health determined by different risk factors. It explains how mental stigma is originating and what we can do to reduce mental stigma, and it talks briefly about vulnerable groups, including refugees and migrants and medical students. So that is the part on mental health. I don't know if there are any questions.
So thank you very much. If you have questions, feel free to ask them. Currently, there's a box where you can basically write down, hello, my name is, and I have that questions. You don't have to tell us your name, that's totally fine. You can just ask questions. And if you want to ask questions after the webinar, feel free to send an email to rdeurope@ifmsa.org. And then I will forward the questions to the relevant person, and the relevant person will then answer your question, whatever it is, regarding the topics, of course. So let's jump to the next position or priority proposal of vaccination. Once again, we will have as speaker our wonderful General Assistant, Valentina.
Okay, so this is the next. We'll start with priority proposal on vaccination. So if we talk a little bit about why should we do this in Europe, it is that we're currently experiencing outbreaks of vaccine preventable disease, smallpox and other infectious diseases like influenza, and the herd immunity is falling because of vaccination hesitancy, and this is the thing that it's not acceptable, because vaccine preventable diseases, they don't respect borders, they can move freely from one European country to another and put at risk the whole European population. As stakeholders, we listed down European Commission, WHO, ECDC, Gavi, the Vaccine Alliance, and European Medical Agency. So if we jump now to the priority and to the next slide, we see IFMSA position. As I said, we said that dying of vaccine preventable diseases is unacceptable, and another thing is that we can lose the polio-free status of Europe, and we just want to spread the information and nurture the herd immunity of as well healthcare workers and general public. And if we go on, we are calling to the next slide, please. We're calling to European governments, WHO, medical faculties, IFMSA, NMOs. What can we do? So we started that we should, if we just briefly go through all the things, the core thing to do is like to address what vaccination hesitancy is and what can we actually do with all the data that we have, because coverage is falling, and if we don't assure the coverage, we lose the immunity, the herd immunity, and then we have the outbreaks. We can try to bust myths and guidelines, there's a typo, so misinformation. We can develop guidelines and national vaccination plans and then try to put them in practice. So to the WHO, that goes up-to-date electronic information on vaccination status, provide understandable, transparent, objective information about vaccination and as well as vaccine safeties. To medical faculties, ensure the appropriate training, try to support the research and innovation of new vaccines. As IFMSA members, we can just raise awareness, try to get to as many people as we can and present scientific evidence, but bust the myths, show that what consequences of not vaccination bring, and show that there is a lot of benefits.
All right, thank you very much. Are there any questions?
And
so far,
all. So are there any questions about vaccination?
Is anyone looking at the wonderful screen of YouTube? Because I can't see it, whether there are questions.
There are no questions so far.
No questions so far. All right. Thank you very much, Valentina. So we will continue with eHealth. For this one, I sadly cannot call for any speakers because I am the speaker. So what is eHealth, basically? Before we start on that one, we have to remember that knowledge is power. And especially in healthcare is knowledge power, because the more we know about a patient, the better we can do the treatment. Because if we know every aspect surrounded of that patient, we can say basically, okay, that person has this disease, and for the best treatment for that person would be that drug. So in eHealth, all of these information come together. For example, that we have a collective data of pictures or lab tests of history, patient's history, and everything related to that one patient without the patient bringing it to the office, because often patients maybe lose their medical data or they don't have them with them in an emergency case. So eHealth is basically tackling from a health perspective point of view those issues. If we go in the definition of WHO, we have eHealth is the use of information and communication technologies for health. So we aim basically to have a network of information that is using today's technology to have an idea or to have a data collection that can be used for research, it can be used for treatment, and for way more opportunities to bring health or better health to the people. And that's why for about 20 years now, there are different governments and institutions working on eHealth ideas. And since 1993, so even more than 20 years ago, Estonia is one of the biggest leading countries in terms of eHealth. They used basically after the breakdown of the UdSSR, the opportunity to go digital, and by now Estonia has a very good point of view, of my personal point of view, structure in eHealth. So if it comes to stakeholders in the European region for eHealth, we of course have the European Public Health Alliance, whom we cooperating with AMR at the current point of view, but also in the future, depending on our priorities that we will vote on in August meeting. So these are basically our prolonged arm regarding the European Commissions and the European happenings in Brussels. So we as IFMSA have the opportunity to talk with them, to tell them, hey, we believe in these opportunities that we want to see, and they will most likely integrate it in their work and promote our position too. Then there's the European Commission, who is on 3 pillars working on eHealth. For example, the secure data access and sharing, the connection and sharing health data for research, faster diagnosis, and improved health. And the 3rd pillar is strengthening citizen empowerment and individuals' care through digital services. But also the European Parliament Committee, so the MVPs, are working on eHealth matters. For example, even the end of May implemented GDPR is a huge aspect of eHealth, as personal data is used and their citizens have to be somehow guarded before the spread of the personal data and how the personal data is used. So it's a huge point we can address. And of course, the WHO regional office is also working on eHealth, but also on a global level, WHO is working on that topic. If we break it down for what IFMSA is working on a global level on eHealth, we, for example, have a crossover with universal healthcare coverage or health equity and social determination of health. Then there's influence of eHealth in the policies of rural health, because basically if we have a remote doctor, some doctor sitting somewhere else, and is able to make diagnosis via the remote, we can improve healthcare at the rural area. And of course, access to medicine is also a topic that is crossing with eHealth. So I just took 3 examples here from the IFMSA position, like in the other policy papers. And we have basically called governments, call different stakeholders, and also call us medical students for action on these points. For example, these points are the invest and develop of modern national eHealth systems of good quality, ensure that health data is secure, accessible to citizens. As I just said previously, it's it's data that will be used, and health data is the most vulnerable because we as human beings, health is our most important subject. And if that data is misused, there's a huge problem in healthcare general. Then there's the call for action for investment and research on eHealth and its implications for health to ensure evidence-based use of the technology. So once again, we have data, big data basically, and we want, for example, to go the next step to make case studies or whatsoever based on that data, but there has to be somehow a system that we can use that information, and not everyone can access it. And as I mentioned, we as medical students, we are the forefront. We're the new generations who are raised with technology in terms of computers and other devices. So we can raise awareness about eHealth and its implementation for the future of health among healthcare students and workers. That will, in the long term, hopefully, for example, reduce the workload of all healthcare workers. All right, quite a lot of information at once. You can always read the papers either by following the link that will be shared in the chat right now, or by contacting your NMO president, and they can provide you with all the documents. So we're giving you here just a brief idea on what's happening, and happening is a good word. Let's continue the happening with the next speaker. We will talk about the empowerment and rights protection of the LGBTQI plus community. And there we have Friederike, our regional assistant for SCORA.
Hello, everybody. I hope you can hear me well. Again, I'm Friederike, and I was responsible for this policy paper, so I would like to introduce why we chose empowerment and rights protection as a priority first, because maybe protecting the LGBTQI plus community might seem to you as a very SCORA-focused topic, so I want to emphasize a bit why this is of a cross-cutting necessity, and why this is a concern of all of us. So explaining our first slide, maybe Birk, you can click. Exactly. So why did we choose this as a proposal for a priority? The people that identify within the LGBTQI plus spectrum form a big part of our patient spectrum. For example, in Europe, there has been recent data saying that 16% of the Europeans between the age of 14 and 29 identify as lesbian, gay, bisexual, transgender, queer, intersexual, or other identities that are not heterosexual or not cisgender. So this is quite a bit, and we have to acknowledge that when we treat our patients and consider all of us being in the healthcare system later in our profession. And the discrimination that this minority faces is directly reflected in the healthcare systems that we have in Europe. So by prioritizing their protection of their rights, their inclusion, and the opposition to their discrimination is, for us, taking on a social responsibility to eliminate inequalities between people of different gender, different sex, different gender expression, different sexual orientation, and others. And the opportunities that we have in IFMSA is to expand our commitment to achieve the zero discrimination. So we can take responsibility as the future health workforce to educate ourselves well in order to be able to be a generation of healthcare workers that can cater to the different needs of minority populations that we meet in our everyday work. And also we can make demands towards the healthcare systems to make structural changes and systematical changes for the better recognition of minorities and their protection. And this is of cross-cutting necessity, as I already said. It gives us a chance to work on this from many perspectives that our standing committee reflects. the rights of this community is not only a SCORA issue, as we're not talking only about sexual health and reproductive health. We are talking about discrimination that these people face in all areas of healthcare, no matter what illness or which healthcare institution they visit. So this is very much about human rights protection of SCORP, about SCOME in the terms of developing medical curricula in order to achieve this zero discrimination behavior, but also of, for example, public health when we talk about prevention strategies that work well. Exactly, this is how I want to explain that we have like a joint responsibility to tackle this issue and serve the community. And maybe, Birk, can you click to the next slide? I'm not going to read out the whole policy paper to you, but I want to highlight some of the information that you can find in there that you can keep in mind. So the position paper is distributed into 5 parts. It talks about the recognition of international human rights that relate to the LGBTQI plus community. And it also showcases some data that we have in Europe, especially on LGBTQI plus related stigma and discrimination, on the health regarded situation, on related hate speech and hate crime that again affects the access to healthcare, but also on recent measures that are taken already in the European region by European bodies and also by national governments. The point that you see in the slides is something that I've picked because it directly relates to the healthcare situation. It says that 1 in 10 respondents of the LGBT community in a survey that was conducted of the European Union Agency for Fundamental Rights reported that they have experienced discrimination by healthcare professionals within the past 12 months. For transgender individuals, this is even more. This is almost 20% of people that face discrimination and therefore not only have limited options in healthcare and do not receive comprehensive healthcare options, but also avoid going to healthcare facilities and accessing the options that they have. These data is collected from 2 surveys that we've been conducting in the past 8 years. So it's really, really new in the European Union that we pay so much attention to it, and that we actually have some data that we can showcase. And so this is also something that we call for if we now want to work on this further. So I'm going to come to the call for action. First of all, we want to showcase the differences that we find when it comes to people differentiated by their sexual orientation, by their sex, and by their gender. And we call out to not only political parties as European national governments and international bodies as the Council of Europe or as the European Parliament, but we also call out to medical universities, to healthcare institutes, to hospitals and other healthcare settings, as well as students' organizations and our national member organizations to following these data and these evidence on discrimination, opposed to any form of discrimination. That is not only opposing to violence that is happening or harassment or restriction of healthcare, but also ensure that no laws are in place that reinforce stigma, that reinforce differences, and that differentiate between rights of the respective people. We call for the protection of sexual and reproductive rights. That is especially in healthcare when it comes to family planning opportunities, when it comes to consultation on prevention, when it comes to the comprehensiveness of the medical history taking that we do, and when it also comes to basic access to healthcare that is often restricted for the LGBTQI plus community by, for example, healthcare providers having discriminatory attitudes or refusing giving access to healthcare or not offering a comprehensive set of opportunities of treatment based on their personal perceptions. And another important thing is that we, of course, call for comprehensive medical curriculum training that should train the future healthcare generation for being very inclusive in their healthcare, for knowing how to serve needs of the LGBTQI+ community, and also have a bigger vision on where healthcare is needed, where access is limited, and what we can do as individuals about it. There are many more calls, and I'm not gonna refer to them all, so I'm gonna stop here. And please, I want to encourage you to ask me questions if you have any more, and I'll be happy to answer them as best as I can.
So are there any questions? Kim, can you give me an update on that one?
Doesn't seem like it.
All right, thank you very much, Friederike. All right, our next topic is of personal concern as me being a medical student studying abroad. And for that one, I would like to introduce you, Katarina, our regional assistant for the Standing Committee on Medical Students Education, or medical education to be precise, to the floor.
Hey. So, Bert, can you move to the next slide, please? Yes. Okay. So we're going to talk a bit about ELF workforce, like everyone previously did. Why medical students should advocate for the health workforce, and why do we need a policy on the health workforce for the European region? As Bert said, it is a personal issue, not only to them, to him that moved away from his country to study, but everyone else. If we're talking about having health-centered, people-centered health systems, if we're talking about achieving universal health coverage and having health systems that are adequately provisioned for the health needs of the population, we're going to need doctors to be educated for it. We're going to need the right number of doctors for the number of people that may need health, so healthcare. So it is about it is a personal issue for everyone, and everyone should have that idea. So what I'm trying to say is that we need to understand that by being medical students, we are the future of health workforce, and by being the future of health workforce, we need to be accountable for it, and that's why we should advocate for the health workforce. I'm from Portugal, and my NMO started working on this in 2009 as a priority, and we focused on. There were decisions on residency. There were decisions on national access to the specialty exam, and we just created positions. And there was even an action where there was a march between the Ministry of Higher Education to the Ministry of Health, because these two should be coordinated and these two should be working with each other, because one is responsible for us as medical students, and the other one will be responsible after we're going to be medical doctors and after we graduate. And if these two aren't in synchrony, what will happen is that we graduate too many medical students for the spots that we have. We graduate doctors that are not educated to work on the population. So we did this action. And we advocated in many ways. We went to meetings. We invited people for our congresses. And what we got with that is that in the small working groups that led after those moments in 2012, we not only had a voice, but we actually had a seat at the table with a voice and a voting right for the national access examination and for the internship year. So that kind of goes to show you how, if we really work on health workforce as a priority, we can impact changes not only in a strict way of changing the number of medical students that graduate or changing the number of spots for residency programs, but we can actually, for example, change how the specialty access is or the internship is and the curriculum of medical schools. So going in a bit about the European region, and Berk, if you can move the next slide. I outlined here what you will see if you open the policy document, and it is a short introduction, but it says all. We need the right number of healthcare professionals with the right skills working in the right place, so there aren't no shortages, and the perception of the public, and actually the public as the healthcare that it needs to be provided. The European region. And why is it important for the European region? I told you that I would answer that question. And this kind of, if you see the global health workforce priority, you will see that we have tackled mostly the same issues, but we don't have one thing that is extremely important that we have in the European region, which is the facilitated mobility. The freedom of movement gives us the opportunity of very easily go from Germany to Bulgaria to study. We don't need visas. We don't need a lot of processes in recognition of qualifications if we want to migrate as medical doctors from one place to the other. What will that create is actually national imbalances, because the doctors that we are graduating may not be the doctors that will work on the country. So should we be graduating enough doctors and provision the ones that are going abroad? Should we trying to meet the country's healthcare demands? This is a complex system, and what we have tried to do with the policy document is trying to take it step by step. Why is this important for the European region? Given the facilitated mobility and understanding that we, of course, like the freedom of movement, we want to use it and have it in a good way, but we don't want the other way around, which are the national imbalances. We don't want the shortages or migrating when you really don't need to or you really don't want to, but you have to, because your National Health Service needs doctors, but for some reason there are not enough spots. So moving on to the next slide. So what are we asking for? We're asking for investment in the health workforce. We're asking countries to acknowledge that when you're investing into health workforce, and we have a lot of statistics if you go through the policy that say exactly this, the health sector is the largest and most rapid sector right now. When we had the economic crisis, all the other sectors did not grow, but the health sector continued to grow. And the health sector employs a lot of people in the EU. So investing in the health workforce is not just a matter of public health, it's not just a matter of taking care of the future health workforce, but it is actually an economic argument as well. We also ask for ensuring proper planning, and this is not, it has to be a multi-stakeholder approach. I told you about the Ministry of Education and the Ministry of Health actually aligning. We're talking about the medical schools actually understanding what are the health needs of the population and designing curriculums that address those conditions. We're talking about a quality education where there are not too many students per teacher, and we're not too many students trying to learn something out of one patient in one infirmary. And we're talking about decent working conditions. Kim talked a bit about mental health and talked about the issues with mental health, and we can talk about the mental and the physical well-being of the healthcare professionals, that by having too many hours of work because there are not enough doctors in the health system, by having too many the responsibilities for their competencies, by not having the right competencies and not being educated in the right competencies, are struggling and are not in a good environment and a safe environment. And another important thing is that we need to acknowledge that health workforce, it is about meeting the health needs, and it is about a greater goal. However, we also need to acknowledge, and we as medical students should be asking for a better outcome and a better opportunity for us as healthcare professionals, enabling personal and professional development by us actually having the right for a choice to be either going to Germany to study because we want to, or staying in our country and actually earning a good wage and having good working conditions with time to leisure and create a family, whatever we want. We should also be advocating for that. Going to the next slide. So, overview on the position paper. What we've tried here is not duplicate the global policy document. So we didn't want to go over the same arguments. We want to focus on the European region. So the first thing would be the European policies. So what were the European policies implemented? And starting with the WHO Regional Committee, but also the European Commission. What were the actions that we've taken? And let's bear in mind that we already had health workforce as a priority. At the time, it was called Human Resources for Health. And we already had that as a priority. And what we got with that was actually being part of a joint action and being having that seat of the table that I was talking previously with the European Commission, and that joint action actually had incredible outcomes in terms of documents and guidelines to have proper planning of health workforce and to be implemented at a national level. So and this joint action will be followed up with a joint tender that was created in 2017. So we talk about a bit about the European policies that were in place and the European policies and the European opportunities right now. Then we go into availability, and we usually see in when we are talking about health workforce about 18 million health workers shortages globally. And let's take it back to the European region, and we think that the shortages will only happen in the low and middle income countries. That is true, but 1 million of shortages will be for the European region. So we'll have 1 million health workforce workers shortages by 2020, and we need to tackle that. And we have an aging population. We're always saying that. We're talking about how important it is to address non-communicable diseases, but that leaves a burden to the health systems that makes us need more doctors or more resilient health systems that actually work on the prevention of these diseases and accompanying the healthcare professionals. The healthcare, not healthcare professionals. And then we go into mobility, and this set the tone for we understanding that this was an important topic for the European region, the facilitated mobility. And when you go into the policy, what you will see is many examples how sometimes we could understand the international migration as a solution for the staff shortages. Certainly, most countries have been doing that. The UK has been importing doctors. Germany, after not being able to study in Germany, actually doctors go back to Germany, and Germany has a very big pool of foreign trained doctors. And what you understand is that even though there are these migration flows, there's still difficulties in recruiting and retaining healthcare professionals in certain professions, in specialties, in fields of practice, and in geographic distribution. Most of the rural areas are in deficit of doctors, and right doctors as well. And that leaves us to the quality. And the quality, it is that we want doctors fit for purpose. So we should be educating doctors fit for purpose. And we should acknowledge that, for example, increasing the number of medical students, again, it is a possible solution. And what we try to explain in the policy document is that maybe it's not the right solution, because as a standalone measure, to enable it won't enable the retention or recruitment of healthcare professionals, because if you have a large pool of medical students graduating, and you only have that measure to tackle the shortages, most probably the alignment in the postgraduate education will not be done. So these doctors won't have a spot to specialize, won't have a spot to work, and they will be even maybe forced to migrate. So this conclusions refers back to the investment of health workforce and the importance of actually addressing this as a public health matter, as we medical students taking accountability for it. And this was mostly done, as I just explained you, in the position paper. Next slide. Can you, yeah, okay, I think, yeah, now it is. Yeah. Sorry, yeah, thank you. So let's make health workforce our priority, and why I think that I try to explain you this along what I've been saying, but 3 important reasons. An opportunity. The European Commission, as a joint tender, they have invited IFMSA to be part of it. We have been part of the previous one, the joint action. So we should seize this opportunity to work with a major stakeholder for Europe and actually develop things with them. Also, there has been efforts to strengthen the data, because what we have been understanding is that with the freedom of movement and with the different organization of health systems, we cannot track how many doctors are leaving, how many doctors are staying, why they are leaving, why are they staying. And there has been a lot of efforts with the WHO and with the European Commission to strengthen the data and to actually understand and get the numbers so we can take action on them. So this is an opportunity as well, because as these efforts are being undertaken right now, we should be part of that as IFMSA. And it is urgent. 1 million shortages by 2020. We're 2 years away from that. Most of us in some way are feeling the problem with not having a proper health workforce planning, whether it is by a curriculum that is outdated and that does not meet the actual needs of the health systems, whether it is by not knowing if we're going to stay in a country, in the country that we would even like to stay, but we don't have the possibility to do it, and we don't have the opportunities for personal or professional development. And lastly, the scope. And this is something that is usually said when there is talks about health workforce, which is there is no universal health coverage. There is no health for all without health workforce to deliver the healthcare. So if we want the doctors fit for purpose, we should be educating them. And if we actually want a health system that meets the health needs of the population, we should be first educating healthcare professionals on how to do it, and should be addressing that we need the people to implement these changes. And I think that's it. Any question? I'm not seeing any.
All right, thank you very much. As I said, question time once again, but if there are any questions for any topics related to that webinar, feel free to send them to rdeurope@ifmsa.org. Post them right now into the chat. We can go back to that one. So I repeat once again, rdeurope@ifmsa.org, or send them in the chat right now. I will wait for short until continuing to the next point. Good. Once again, I would like to highlight you can like, subscribe, and be part of the notification squad of IFMSA by taking care about your social media YouTube account. You can like that video, subscribe to the IFMSA YouTube channel, and hit that little bell to get notified in the long mass. I would like to use that opportunity additionally to thank everyone who contributed by giving input, by helping working on the documents to create these documents. Big kudos to everyone involved, and I hope to see you at August meeting 2018 in Montreal. Bye-bye.